Welcome to our fifth Trauma Anesthesiology Society podcast. I am once again Dr. Joshua Sappenfield, and I'm here with Dr. Kevin Blaine. Thank you, Doc Matters, for hosting. These podcast discussions have actually become quite fun to produce, and we've talked about pre-hospital transfusions, research in trauma, various modes for analgesia for rib fractures, including some newer, less studied ones that I've never heard of before. I think the most interesting thing that I have learned is that disruption of fascial planes by rib fracture may actually help with analgesia with some of these newer blocks. And for this podcast, Kevin and I decided that we will discuss probably the biggest study published on trauma this year, the CRASH3 study. I will briefly go over the history of tranexamic acid. Kevin will give a 2,000-foot look at the study, and we'll both kind of give a deeper dive in the study and some discussion points, and hopefully it'll generate more discussion in our community. So some background information of tranexamic acid that you probably don't know is first, it has its own comic book, which is kind of crazy in itself if you think about it. It kind of came big in trauma back in 2010 when it was included in a randomized prospective double-blind placebo-controlled study. And actually, it's now the only drug to show benefit in trauma in a essentially level 1 evidence study. It's currently included as part of the resuscitation guidelines of the Eastern Association of Surgeon Trauma back in 2017, the NATO Blood Panel back in 2016, the Pan-European Multidisciplinary Task Force for Advanced Bleeding Care and Trauma in 2019, that was the update, and Tactical Combat Casualty Care in 2017. So a lot of this is supposedly working around fibrolysis. Fibrolysis is identified to occur in massive trauma in a significant portion of patients, greatly increasing the risk of exsanguination and death. And the more we study, the more we know. There's at least 4 phenotypes of patients that present from trauma. You have your hyperfibrinolytic patients that start consuming their coagulation factors and become very fibrinolytic. And so by the time they come to the hospital, they've consumed most of their factors that continue to break down clots. You have what some people are calling physiologic fibrinolysis activity, where in the pre-hospital phase, pre-provider phase, they become hyperfibrinolytic, but some of the natural negative feedback loops start slowing down this fibrinolysis, and they start developing more stable clots by the time you hit to the emergency department and go to the operating room in the ICU. Then you have the hypofibrinolytic group that for whatever reason, either they don't generate the endogenous TPA or they don't respond to TPA, never generate that fibrolysis phase, and they continue making stable clots from the pre-hospital phase all the way to their hospital course. And then you have this scary group that acutely develops hyperfibrinolysis, but then have an abrupt shutdown of the fibrolysis phase, which possibly occurs in the pre-hospital phase before they arrive at the emergency department. And really none of the coagulation studies we currently do can really study these in a good time-wise fashion for us to know more in depth which patients are in which phenotype at any given point. We don't have a good way of tracing that. So how does tranexamic acid work? Well, we don't know. There is multiple possible pathways. The most popular is that it prevents the breakdown of clots in the body. It actually doesn't generate clots. It just stops clots forming for breaking down. But it could possibly affect complement. We already know that some of the toxicity causing seizures is by GABA activation. We know that it's involved with cellular inflammatory cytokines. There's actually rat models where when they give tranexamic acid, either before injury or during injury, that there's a decrease in inflammatory cytokines that are released, and there's less lung water accumulation. We also know that it's a lysine analog, so it could be involved with lysine signaling pathways. We know it has an effect on bradykinin and histamine. all these give some interesting possible pathways for a decrease in inflammation and injury pathways in trauma. However, if it does work by inhibiting the breakdown of clots, it stops kind of this interaction between the endothelial cells and the essentially coagulation factors in the bloodstream. And so your endothelial cells have these Weibel pallid bodies that release TPA and von Willebrand's factors, which affects when it releases the TPA, then cleaves plasminogen into plasmin, which breaks down fibrin clots. And so the TXA would prevent that plasminogen from being cleaved into plasmin to have that fast fibrolysis of fibrin. So you really can't talk about tranexamic acid without going into the CRASH2 study, and I'll try to give a brief overview, but essentially it was a placebo-controlled, double-blinded, randomized controlled trial with 20,000 patients. The inclusion criteria was a systolic blood pressure less than 90, a heart rate greater than 110, or physician discretion. And they found a 1.5% absolute reduction in mortality. That's a number needed to treat of 67. In the study, they didn't find any increase in thromboembolic events. So some of the limitations, well, many of the patients actually came from countries without modern trauma systems. And so one of the biggest criticisms of the study was that it's not generalizable to countries with a modern trauma system, that there might not be such a great effect seen. The inclusion criteria actually were non-specific for hemorrhage, having a systolic less than 90, a heart rate greater than 110. I mean, there's other things that can cause that in trauma. And actually, when they looked at it, only half the patients met both the blood pressure and the heart rate criteria. And so there was a lot of physician discretion going on whether they should be included in the study. There was no real surveillance of non-fatal atherosclerotic events. I mean, I guess you definitely pick up your strokes and your MIs and your saddle embolus, but they weren't doing ultrasounds of legs for DVTs and such. And so it's not really a great study to look to see if there's an increase in atherosclerotic events. They didn't have any injury severity score recorded, and so it's hard to compare observed versus expected ratios for mortality in this study versus other studies. And they didn't have any labs, and so they actually don't have any lab data to know which patients benefit from tranexamic acid and which ones didn't. They didn't see a reduction in transfusion in the studies, which is kind of concerning since the study was supposed to be on significant hemorrhage. However, that actually might be one of the biggest boons of this study. It turns out, which we'll talk about a little bit later, that transfusions of packed red blood cells and platelets actually cause fibrolysis shutdown. And so this study actually would not have that as a confounding factor whether or not tranexamic acid causes mortality or not. And we already kind of talked about this, but this study was actually underpowered to detect a difference in major vaso-occlusive events. Based on the incidence of blood clot events in this study, I mean, I'm not a statistician, but I did a rough calculation and only had the precision to calculate what the known incidence of vaso-occlusive events was in the study. You would actually need twice as many patients to see if there was a difference between the two with the precision needed to do that. However, up to this point, this is the only level 1 study we have looking at tranexamic acid. And so while these are some methodological issues and limitations of the study, I mean, and the land of the blind, the man with one eye is king. There's not really anything to really criticize this out. If you look at all the other studies with the same amount of scrutiny, nothing would hold up, and you would have any basis for giving tranexamic acid in trauma. And so one of the big things that did come out of the CRASH2 study was there was an increased mortality seen after 3 hours. And you have to ask yourself, what happens at 3 hours that tranexamic acid would increase the mortality with? And as I talked about earlier, when you look at those phenotypes for fibrolysis, people start generating more stable clots about 3 hours. And so tranexamic acid probably doesn't have a benefit if that's the if that's the mechanism. And actually, it could make people that already forming stable clots make even more stable clots, and they might form these in inappropriate positions. So criticisms for tranexamic acid. One of the biggest criticisms is the effect is small and insignificant. As we talked about for the CRASH2 study, the number needed to treat was 67 with only an absolute reduction in mortality of 1.5%. People are like, what am I going to do with 1.5%? It doesn't sound like that's much of an effect. Well, I looked at all the patients in the CRASH2 study that got tranexamic acid before 3 hours, and I pulled their mortality data. And then I kind of cheating because we haven't talked about CRASH3 study yet, but I thought that they were similar enough that they had the same sites that enrolled the CRASH2 study were involved with the CRASH3 studies. They had the same mechanism for blinding and for administering tranexamic acid. And so I actually took the mortality data for people who received tranexamic for 3 hours in the CRASH3 study. I pulled it, and I got a relative risk reduction, 0.87, 95% confidence interval, 0.81, 0.94, using a fixed model for meta-analysis. And once again, I'm not a statistician, but the absolute risk reduction would be 1.95 based on that, with a number needed to treat of 51. And then at my hospital, tranexamic acid costs $12.20 a vial. And so looking at the number of trauma mortalities in the United States, it's about 110,000. If you do the math, the lives saved with tranexamic acid would be about 2,100 to 2,200 patients in the United States. If we gave tranexamic acid to everyone within 3 hours before trauma, cost per life saved would be $1,240-ish. And so, well, I don't know if we should administer tranexamic acid in this way. There's kind of a rough eyeballing whether this is significant or not. And I'm looking at this, I mean, that's the day of a hospital stay. And that's half the cost of someone staying in the ICU for a day. That is on a ventilator. When you think about interventions of Roboa and ECMO, that's actually pretty cheap to save a life. And so I know 1.5% doesn't seem like a big reduction in mortality, but when you look at the cost of the intervention, I'd say it's pretty significant. Some people also criticize that the CRASH2 was not generalizable US, and so we don't know what kind of effect on the US. Well, they actually did a subgroup analysis of all the different areas of the world that the CRASH2 study was done, and Europe, Australia, North America made up 1,960 of those patients. There was no heterogeneity with the results. And actually, the greatest risk ratio, or I guess the least risk ratio, 0.63, was seen in the Europe and Australia, North America countries that recruited patients. And so if anything, that meant tranexamic acid possibly had a greater effect in modern trauma systems. And that potentially could be because they're getting tranexamic acid faster, which I'll talk about a little bit later. And I want to go over one study real briefly. It's the Miki et al. Study that came out, and it was actually done in the United States. And so it has a modern trauma system. This study was a cohort, prospective cohort versus retrospective control that had 724 adult trauma patients. Mean time to tranexamic acid was 33 minutes. So if you're giving tranexamic acid by the Li-30 on your tag, your average time is about 48 minutes from drawing your tag to get that number. And so meantime tranexamic acid in this study was 33 minutes. That would mean in this study, you'd have to draw the tag before the patient was in the car accident to give tranexamic acid the study based on tag data. And so they're getting tranexamic acid way before you could ever do it by lab analysis. And the interesting thing is there was a reduction in 28-day mortality, 3.6% versus 8.3%, so the odds ratio of 0.41. I mean, that's huge. Length of stay was even reduced for hospital days from 4 days from 8 days. And once again, there was no clotting studies performed prior to the administration of tranexamic acid because they gave tranexamic acid so quickly. Limitation studies, it wasn't randomized or blinded. there's not enough power to detect the adverse events, and there was no reporting of transport times or time to the OR. But when you look at this, you combine the CRASH2 study, and hopefully we'll talk about the CRASH3 study, I mean, timing to give transamin acid seems to be really important. And so, I mean, I talked about how before the pre-hospital phase, most of your patients are going to be in this slightly hyperfibrinolytic phase, except for a couple subgroups. By the time they get through your emergency department, when you're doing your early blood draw, your acute shutdown group is going to definitely be have a low fibrinolytic activity. So is your hypofibrinolytic. This is about when your physiologic fibrinolysis group starts coming down. And if you wait 43 minutes after they get to the emergency room to 48 minutes to look at your life 30 to give things, they're even farther down this cascade. And so doing lab draws might actually put patients in an area where they would not receive tranexamic acid. And so there's a couple of studies that look at this fibrolysis shutdown group. There's Mizo et al. It was published in 2017. Quickly, they gave tranexamic acid at 2.21 hours after injury, plus or minus 1.97 hours. And so we're getting close to that 3-hour window where you have an increase in mortality with given tranexamic acid. However, the time to tag was 26 hours after injury. And so this is more than 10 elimination half-lives after tranexamic acid. It's hard to really know what that data really means. There was way more massive transfusions in the interventional group, which once is a huge confounding factor, which we're not sure if it's a linear relationship or whatever for tranexamic acid causing fibrinolysis shutdown. There was no reporting of transport times, need for the OR, time to the OR. And so I'm really not sure what to do with the data with that study. And the last one was Moore et al. Called tranexamic acid is associated with increased mortality in patients with physiologic fibrolysis. They only had 26 patients in their tranexamic acid group. They were more severely injured, had greater massive transfusion requirements, higher mortality, more likely to die from hemorrhage. I mean, right there I'm seeing some huge confounding factors that I don't think really lend themselves to multivariate analysis, since we're not sure of all of the associations between them. And tranexamic acid in this group was usually given as a breach of protocol. And so, I mean, I guess I disagree with the authors with their conclusion of the study. I think the only thing the study is really showing is tranexamic acid is not a magic tourniquet that stops bleeding over the body that's going to save people that are dying or bleeding for other causes. And so I'm going to give this up to now Kevin Blaine to give his intro talk to the CRASH3 study.
Thank you, Josh. That was an excellent discussion, and it sets a very high bar for me. So back when I was a postdoc fellow at the National Institutes of Health some years ago, we would often dissect study design before we even got to the results. Because even if you find the results compelling, sometimes the methods are so poor or maybe questionable that the authors might not have proven their point. There are always problems with studies, every single one. And while you can't be rigorously reductionist all the time, or else you can't read evidence-based medicine, just because someone did the best study they could doesn't always mean that it's a good study. And we should always be careful that we don't start implementing therapies that haven't been thoroughly investigated, because we don't want to start hurting people by misapplying results. So let's begin. As Josh mentioned, CRASH3 was a follow-up study to CRASH2. The open question from the previous study, as far as the authors were concerned, is whether TXA could reduce mortality from severe intracranial bleeding in patients with traumatic brain injury. So let's brainstorm this a bit. What kind of study do we want to see? What are the characteristics of a good study for CRASH3? Broadly, we want to see a representative, generalizable study. And this one recruited patients from all over the world, so check. It's important to have a sample size that's big enough to see a difference. They seem to be adequately powered at 12,000 patients. I mean, that's enormous for a trauma trial. It leaves enough room for subgroup analyses and the ability to look at resources, resource availability or regions, so big check. We want randomization, check. Investigators and clinicians should be blinded, check. Is there active data safety monitoring? Check. A plan for informed consent? Check. The preferred power for a large trial anymore is 90%. They're at 90%. Check. Are the financial conflicts of interest controlled? Check. Now, what about controls and confounders? Well, Josh and I will discuss those in just a second. But let's talk about the protocol. Recruited patients were randomized to receive either TXA or a saline placebo, after which time all other clinical care was left to the discretion of the treating physicians. This is what's meant by calling it a pragmatic trial, although a cynic might call it a sloppy trial. Personally, I like the move towards these open study designs that allow for clinicians to vary care appropriately as required to keep the patient healthy and make them better. But we have to admit, it does introduce a lot of variability and confounding that can make the results difficult to interpret. Ultimately, this tends to increase the sample size you need for a study. Well-conducted studies should maintain the same study protocol throughout the trial. If a study changes its protocol mid-trial, then you have to worry about the biases these changes will introduce. Take, for example, the original Zygris trial for sepsis. It changed its enrollment midway through the trial to exclude the sicker patients, and because of that change, they were able to reach statistical significance. Zygris, of course, was later removed from both the American and European markets following 4 follow-up studies that actually not only didn't really show a benefit, but showed harm. CRASH3 originally allowed patients within 8 hours of their injury to be enrolled, but later when they got some subsequent data demonstrating that there may not be benefit in patients who receive TXA after 3 hours, they shortened their enrollment window. That's probably the right call. I think it would be unethical to continue recruiting patients to therapies if you don't think it will benefit them. And ethics are always more important than methodologic purity. But if we're trying to read science strictly from an empirical standpoint, that is a study weakness. The primary outcome, the most important thing that this study measures, is death from head-related injury within 28 days. Now, I'm not too satisfied with this mortality endpoint. Death is statistically useful because it's binary, right? You're dead or you're not, and it's compelling because we don't want people to die. But it's a bit misleading because we can never be sure the exact cause of death, particularly in these polytrauma patients and after a long course of intensive care. The study also limits death to neurologic causes, but that strikes me as a tough thing to dichotomize. If a patient survives a TBI but is profoundly debilitated, then aspirates and dies of respiratory failure, is that a neurologic death or not? It's not entirely clear to me how rigorously this endpoint was defined. The study protocol that was separately published doesn't actually make it clear exactly how they decided who died from a neurologic cause and who didn't. 28 days might have been too long. In fact, almost half of the neurologic deaths that they reported occurred in the first 24 hours. And if you look at their graph, the deaths really tapered off after 7 days. Most of the patients died in the first quarter of their interval. That kind of surprised me, actually. The classic teaching is that death by TBI is a delayed complication after trauma. Death is also a relatively rare event if you think about it in the population of patients. Now, they've tried to hone in on patients at high risk of death, but still in the overall population, death as an outcome doesn't always happen that often. So in order to use death as an endpoint in any clinical trial, you have to expose a lot of patients to a potentially harmful medication. And there may be reasons that might not be what you want to do. It's possible sometimes that a smaller study looking at an indirect marker, in this case, say functional outcome, might have provided compelling evidence all by itself, albeit with its own study limitations, but with a smaller sample size. They opted to do the trial looking at mortality. Could have been done a different way. There would have been problems, but no study is perfect. It's probably worth mentioning that they excluded anyone presenting with a GCS of 3 or with blown pupils. I'm not real clear why they opted for those 2 different definitions. I think they're reasonable if you're looking for people with very severe brain injury. These patients are probably not going to survive, just epidemiologically speaking. However, I'd bet that if one of these patients rolled into your resuscitation bay and you were a believer in TXA, then you'd probably still want to give it to them. So because they were likely people to receive the drug in clinical practice, I actually think they probably should have been included. Their exclusion is a possible bias, and they do provide a sensitivity analysis, which does give me some degree of reassurance, but you can never account for this bias completely. Let's talk a little bit about the results. So CRASH3 found no significant difference in their 28-day neurologic mortality endpoint. Effectively, that makes this a negative study. But to say that, we have to say a word on powering. So they designed the TRUT study to see a 15% mortality reduction in the group that received TXA. You know, a way to look at that is to say that TXA doesn't necessarily not save lives. It just maybe saves lives with a mortality reduction less than 15%. The study wouldn't ever be able to see that difference. So if you think about it, like a 10% mortality reduction, well, that would be technically invisible in these data, but I would argue that that's still clinically significant. Now, incidentally, if you look at the magnitude of their non-significant effect, it's about a 6.6% reduction, which could still be a useful number if there were no harms associated with TXA. So something to bear in mind, it can be a negative trial statistically, but still have some meaning, particularly if it could be followed up in a different context, maybe a large retrospective database study. So now we move on to the secondary outcomes. The authors pre-specified 10 secondary outcomes, and then if you go back and read their trial, they actually have a line that says, quote, other events to be described, unquote. Ooh, I'd be careful when I hear authors say that they're going to pick secondary endpoints after the fact. Remember, all secondary endpoints are, by definition, hypothesis generation. So if you're picking your outcomes after you have your data, you're picking your hypothesis after you have your data, it's a little bit deceptive. A lot of people also tend to place faith in secondary endpoints, but if we're being really rigorous about how we interpret studies, we really have to just view them as suggestions. So I'd be very careful about making any conclusions or any decisions based solely on secondary outcomes. So if we look at their secondary outcomes, the strongest results that they reported came from a stratified subgroup analysis, a type of secondary endpoint. They pre-planned a stratified analysis based on injury severity, mild, moderate, severe TBI. They reported a mortality improvement in the patients with the least severe injuries. This is, I think, actually really interesting. I would think that the patients at the highest risk of death would benefit the most from a life-saving intervention. And that's because presumably in the patients with milder injuries, a fraction of those, a larger fraction of those, were never going to die in the first place. So they're never going to benefit from an intervention that would keep them from dying. But that's not really what they see here. And whenever I see a counterintuitive result like that, I really kind of want to dig into why. What are we missing here? They propose that these milder injuries benefit because the drug stops bleeding before it's a problem. Maybe, but again, for a large number of these patients, it was never going to be a problem. So that's really just a hypothesis, and we need a lot more work to tease it out. They also look at deaths within 24 hours of injury, and they saw a reduction in the TXA group. That's also interesting and also confusing, because if TXA helps milder TBIs, and the severe TBIs are most likely to die within 24 hours, which seems reasonable to me, then it seems like TXA should not help patients within 24 hours of injury. But it does. So that's kind of a discordant finding with their previous finding that it seems better for people with mild to moderate injury. I don't really spend a lot of time discussing that point, but I think it's worth considering. For this case, the most important secondary endpoint, I think, is probably thrombosis risk. We need to get some sense of how safe this medication is. Because the study isn't really designed or powered to look at secondary endpoints, the investigator should ideally identify as many direct and indirect indicators of thrombosis as possible. Embolic events, DVTs, PEs, ideally by active surveillance, maybe autopsy findings, pertinent lab studies, long-term follow-up data, etc. They have a composite endpoint of all the things that they do look at, and I think that's great, even if it's not significant. But the confidence interval on it is plus minus 25%. And if we're going to question whether a non-significant 6% reduction in mortality is meaningful, then we should also consider if a non-significant risk of thrombosis is also important. There's just not enough evidence here for me to say with confidence that TXA is safe for all TBIs. It would give me more confidence if there were more aggressive surveillance for thrombotic complications. So how can we put this together? I'd say that CRASH3 did not show a mortality benefit for patients with TBI. Maybe patients with mild or moderate TBIs might benefit. And also maybe it's a good salvage drug to consider in patients that look like they're going to die within 24 hours. But either hypothesis remains to be proven. We can't really say for certain that the drug is safe based on these results alone, so I disagree with the authors that they've proven safety by the lack of a statistically significant adverse effect. This is a really interesting study, but we should ask ourselves, does it show that TXA saves lives when given to trauma patients with head bleeds? And with that introduction, let's discuss this article further. Now, Josh, I can spend forever slicing up the CRASH3 trial, but for my own practice, I'm a little bit interested in using TXA for head bleeds. In fact, just yesterday, I got into a major trauma case with a low GCS patient, and I was seriously considering TXA. Now, what are your thoughts about how to implement this trial's results?
Well, so that's kind of the big money question as it is, right? I mean, as clinicians, we're responsible for medical decision makings, even when there's little, poor, or no evidence for an intervention. And we're just as responsible for that patient, live or die, whether we make an intervention or if we decide to do nothing. And I could say, based on the CRASH3 study, that I think it's with good certainty that it's unlikely that tranexamic acid and the dose and the duration given in the CRASH3 study is unlikely to increase mortality, even in the setting of traumatic brain injury. Based on some of the subgroup analysis, I think some patient selection might be warranted based on your clinical judgment. For example, since a patient with more severe traumatic brain injury didn't seem to benefit from tranexamic acid, and these patients are higher risk of DVTs, giving a medication that helps stabilize thrombi may not make as much clinical sense, especially if you don't have any supporting lab data.
Let's talk a little bit about study design. What are your thoughts about the selection of patients in this trial that are based on head trauma?
Well, so I guess I'll start with what I like. I really like that they used a GCS of less than 12 or less than equal to 12 and a supportive CT scan. I think every center that you would want to include in a study like this should have at least those kinds of resources. However, even in trauma centers that are resource constrained, they probably still have at least the ability to do those two things. And so I like that it increases its generalizability and the ability to enroll patients, and it doesn't just include a certain segment of trauma centers that other trauma centers wouldn't necessarily benefit from this kind of intervention. I also like that it's pragmatic. I know that you're not as thrilled about that, but I think it makes the result more likely to be what you'd see in real life when we don't have protocolized treatment patterns for every single patient that comes in. It probably does water down the result, and it adds some confounders, such as treatment patterns and stuff that might contribute to an outcome. I mean, hopefully with optimal randomization that you'd have as just many patients on each treatment side, but I mean, you can't rule that out. What I don't like about the study is they start off including patients up to 8 hours after injury who received tranexamic acid. I know back in 2016, they changed the protocol without looking at their data, so it wouldn't change the power of the study. But I think even from the results from the CRASH2 study, that should have been kind of a no-brainer to only go up to 3 hours after injury. And I'm really not happy that they included at the end patients greater than 12 in their analysis. Based on the exclusion criteria at the beginning of the study and their methods, those patients shouldn't even been enrolled, and that was about 2,500 patients.
Yeah, I was a little, as you know, I was a little concerned about that as well. I do want to put one word that I actually like the fact that it's pragmatic trial. My quibble, and I don't even know if this is a quibble, it's just, you know, the reality of clinical research is that a pragmatic trial is not the cleanest way to get to a result, because there's a lot of unmeasured confounding in a pragmatic trial. From a practical logistical standpoint, especially in something like trauma where there's so much variability, I think it actually behooves you to do a pragmatic trial, and it might even be unethical not to do a pragmatic trial. From a scientific standpoint, it would be a stronger result if it were not a pragmatic trial. I don't know how to do that, but just because the trial is not the trial is the best trial you could do does not mean it's not a methodologic weakness to the trial. I guess just be really nuanced on my point there.
I like that you do that, and I understand now.
I also feel pretty strongly that the modification that they made from 8 to 3 hours, I think that was the right call. I'm methodologically worried about that because I think it weakens the result. But if I were the trial investigators, I would feel ethically obligated to have modified my protocol based on the data that they had, right? You should never give dangerous drugs to patients who are unlikely to benefit.
Let me rephrase that. At the start of the study, they should have known that they should only have included patients up to 3 hours. When they did the CRASH2 study and giving tranexamic after 3 hours increased mortality, and that was a randomized controlled trial, every study after that should have only included patients up to 3 hours.
Okay, that's an excellent and fair point. They probably should have never had an 8-hour endpoint in the first place. How realistic do you think it is to manage trauma patients with a TBI differently at all from trauma patients without a TBI? Most of my polytrauma patients have many injuries. A brain injury is only one of them.
So, on one hand, we are already doing this. I mean, in the setting of intracranial hemorrhage and cervical spine mobility and increased ICPs, we are changing our medical management patients for patients. For example, you wouldn't want to fully heparinize patients for a vascular injury if they had an expanding subdural hematoma. We sometimes leave patients their broken ankles in cast because they have increased ICP, and we don't think that now's the time to take them to the OR to definitively fix their ankle. And so we're already making medical management decisions for people with traumatic brain injury and the like. On the other hand, as you mentioned, this is not fully possible. In the pre-hospital setting, in the early initial evaluation period, we have missed diagnoses. We have diagnoses that we have not made yet because they just haven't had their comprehensive evaluation. And so I think it's actually nice to have an intervention that's safe, safe might not the right, that benefits mortality-wise, even in the setting of traumatic brain injury. I mean, at the time of the CRASH2 study, it was actually, there was a caution to giving tranexamic acid in the setting of intracranial hemorrhage. And so I think this study needed to be done to show that if you gave tranexamic acid to someone who had multiple injuries but also had TBI, that you weren't increasing the mortality because of their traumatic brain injury.
So let's talk a little bit more about this question of pragmatic trials. Leaving aside the impracticality of standardizing care for a critically injured patient across 19 countries with many different trauma systems, how would it affect your opinion of the trial if they had standardized the protocol across the board? Would you be more likely to believe the results or not?
Well, I like that you said, in my opinion, because in reality, no one could truly answer this question in this particular case. We are calculating the probability of what the truth is. I mean, as we talked about before a little bit, the problem with a pragmatic study is that you're not controlling for all the possible confounders, like regional variances in care, availability of resources, and independent clinical decision making. By random chance, one of these could be skewed in one of the treatment arms, which may lead to difference in your observed study. Another problem with tranexamic acid is that we're not completely sure what the mechanism of benefit is. Sure, it's an antifibrolytic, but the dose is small and the elimination half-life is about 2 hours, so it's only in the body for a fairly short time. It also is a lysine analog. It has effects on GABA, histamine, and bradykinin. It also has effects on cytokines of the inflammatory cascade. Since we don't know for sure what the mechanism is, it's hard to make inferences of why certain patient populations may benefit over others. For example, the CRASH3 was on traumatic brain injury while CRASH2 was on multi-trauma. So let me circle back. In my clinical opinion, I believe the result. I think the most important factor is not whether it's pragmatic or standardized, but out of all the level 1 evidence surrounding tranexamic acid use in trauma, that's 2 randomized controlled trials, double-blinded with placebo, showing a fairly homogeneous result. I mean, the second study, CRASH3, because its precision, it was not statistically significant. However, it had almost exactly the same absolute risk reduction of mortality, which means the finding is reproducible. And I believe in things that are reproducible. And I guess I reserve the right to change my opinion on tranexamic acid, its benefit in trauma, if someone can produce a similar or better quality evidence that shows these things are not reproducible.
Now, just to clarify, this is a reproducible result from the same group or similar group, right?
So that's the thing. You have to decide if the patient population in the CRASH2 study is the same population in the CRASH3. One is being multi-trauma and the other is traumatic brain injury, but they both should have probably similar clotting cascades coming to the hospital. They're probably mostly male. You're probably still going to be about 70% blunt injuries, and they're going to have functional body systems at the time of their injury. And so I would make the case that these are almost identical patient populations, especially if you had multi-trauma with a traumatic brain injury. And so I think the results are comparable.
I'm wondering about the investigators, though. The reason being is that if I have built my academic career pushing a certain intervention through multiple trials, all of my trials have certain holes built into them, and some intentionally, some not, and they all come to the same result. It's not, to me, the same thing to say that the study is reproducible than if it's reproducible data in the hands of multiple different investigators.
And so it's true. I would like to see another randomized control trial, possibly a different investigator. However, as we said, there was 19 different sites. It'd be very hard to micromanage every site to make sure everything's being done exactly the same way, treatment patterns and all those. And giving us pragmatic design, it wasn't meant to. And so I would be surprised if another investigator would come up with a different result.
I really want to talk about confounding in this trial, because I think that's the biggest weakness in the study design. It's this inability to account for confounders. A lot of these confounders, they didn't even really try to record. And if you listen to the interviews conducted by the lead author, it's apparent that they simply wanted to use the sample size and the explanation of a, quote, pragmatic trial to basically ignore the confounders. What do you think of that approach?
Well, I think that the investigators didn't want to throw the baby out with the bathwater. I mean, given the sample size, the optimal randomization, and when I compare the evidence of this to other randomized controlled trials that show mortality increases with administering tranexamic TBI, I would have to say the way the evidence kind of supports the use of tranexamic acid. I mean, I'm not saying it's not a confounder, that they had a pragmatic design. But I think the bigger confounders in the study are the fact that 2,500 patients, which was a little bit more than a fifth of patient studies, were included that didn't meet inclusion criteria. And the other one that I think is pretty big is the lack of any description of whether patients receive surgery for the traumatic brain injury. I mean, they showed possibly, I mean, it wasn't statistically significant, but a better outcome in wealthier nations, which is interesting, but we don't have enough information to even speculate why patients in tranexamic acid in wealthier nations would have better outcomes. It was because they had better trauma systems, so they could administer tranexamic acid faster? Was it because they received surgical intervention? If so, we should probably be pushing surgical interventions more rapidly in some of the other countries. I mean, there's all sorts of potential uncontrolled confounders.
And I really struggle with that a bit, because I don't know the distribution of confounders between the two arms. You know, it's possible that there was a difference in injury severity. It's possible that there were differences in coagulation status. You know, there's a lot that goes in there that might have affected the interpretation of the result, and there's a lot that could potentially had been subgroups that they could have pieced out. if your sample size is 12,000, it would be interesting to see if, for example, one particular mechanism of injury might have benefited more than another. There's a lot of information that it's just not there for me to really have a lot of faith in what's basically a blind result of subgroup efficacy or no subgroup efficacy. It's tricky for me to get around the fact that there's a lot of missing data here that I would expect to be there, even in a pragmatic trial.
Yeah, I guess, we've touched on a lot of things. Just quick review, need for surgical intervention, and lab data would be nice to know, those kinds of things. And one of the things I think that'd be really important that is probably not feasible, especially at some of the resource constrained centers, is injury severity score. It'd be nice to know what the observed expected mortality of these patients were and whether the results of the study are comparable to other studies in trauma and what the observed mortality is.
I think this is basically a negative trial. Let me qualify that, that the primary and secondary endpoints are all negative, except they have a pre-planned stratified subgroup analysis that suggested benefits in patients with mild injury and maybe some benefit in patients who died in less than 24 hours. So I kind of find that to be a confusing result because it doesn't seem like the results are telling me a consistent story. Should I be giving TXA to severely injured patients? Should I be giving TXA to mildly injured patients? Do I give it to everyone? Do I give it to no one? How do you synthesize the results of this trial into a coherent story?
In a strict sense of the word, yes, this is a negative study. And I guess when I look at the subgroup analysis, I can't say the findings are all negative. And if this study was done in a vacuum, if there was no other description of tranexamic acid and use of trauma, I guess I wouldn't know how to piece all this information together. The nice thing about the study is it has almost the same collaborators as the CRASH2 study. And the patient populations are likely the same as I talked about before with the same comorbidities. The reason we do p-values, 95% confidence intervals, and the such determine the probability of any result is reproducible, therefore more likely true. Given the whole picture, I am more certain than not that tranexamic acid does not increase mortality in traumatic injury patients, even in the setting of mild traumatic brain injury. In fact, it probably has a benefit. I am uncertain whether or not there's an increase in thrombotic complications or other complications when tranexamic acid is administered. And I think these complications are non-life-threatening and potentially treatable. And I'm still uncertain what the exact mechanism benefit of tranexamic acid would be. I definitely would like to see a lot more bench work on why there is a benefit, so we could possibly parse out who would potentially benefit from tranexamic acid than not. I guess I'm not completely satisfied as giving tranexamic acid as a blanket approach to every patient.
Yeah, I'd kind of agree with that. I think I'm somewhere in the middle on this, and I would agree that it's always tricky to apply a therapy that has shown some epidemiologic evidence of benefit when you're still struggling to understand the basic mechanism of that benefit. Ideally, the tightest story is that you could understand why something benefited from, the bench to the bedside. And I think with TXA, we don't quite have that level of evidence. And to be honest, we may never get that level of evidence.
Well, actually, there's a bunch of drugs now that are finding out we don't know the exact mechanism. Like, we don't know the exact mechanism of how most of our anesthetics work. And we're just now finding out that some of the chemotherapy drugs that we developed to work on certain proteins, when they knock out those proteins in mice, the chemotherapy agents still work. And so there's a whole host of drugs that kind of look like that in medicine.
Yeah, it kind of makes you wonder how much further we've actually traveled from Galen, in 2,000 years. Let's talk a little bit about the safety of TXA. In theory, the safety profile of TXA is very good. Although I'm a little bit nervous about it because I feel like the safety endpoint for me personally, and this is just my baseline assumption of this drug, I'm not confident that we've really worked this drug out in really advanced, thoroughly designed safety trials. generally speaking. A lot of people will challenge me on that, but I mean a trial where the primary endpoint is safety. Now, in this trial, they did not see any adverse outcomes in the primary analysis. But, if we're going to spend a lot of time praising or celebrating a subgroup secondary analysis for its effectiveness in one narrow group of people, then I kind of think it behooves the authors to do the similar kind of detailed analysis of their data looking at the outcomes. I'm also a little concerned that they didn't really surveil for what I would consider the most complicated or the most serious outcomes, thrombosis. They didn't really surveil as aggressively for that as I might liked. And I guess I see that as a failing of due diligence. Now, you're an expert on fibrinolysis and trauma. What's your take on the safety of TXA?
Well, I mean, I can't say they were really powered to determine if there was an increase in DVTs and atheremboli. In the CRASH2 study, they had just enough patients based on their incidence, to determine what the actual incidence of atheremboli and their vaso-occlusive events in their study was. They would need twice as many patients to determine if there was a difference. And I see some review articles. I mean, I also disagree with combining data or using data from general surgery obstetrics. I mean, these are not the same patient populations. There is vastly different clotting profiles between trauma and obstetrics. And so I don't think we really know what the safety profile should be looking like. I don't think that would stop me from using tranexamic acid, but it definitely would make me be more aware of possible side effects of using this medication.
The other thing about it, and this is the other thing that scares me of TXA, is that, thus far, a lot of the trials, relatively speaking, they've used it in a lot of patients, but I don't know that they've used it enough for me to comfortably make a statement of safety. On top of that, you have a number of patient blood management advocates these days that are strongly pushing TXA for a variety of indications, some of which they really haven't been tested for. I've been to meetings, for example, where there are enthusiasts who say that TXA is the greatest drug known to man with no side effects. And that's a quote. Like, that's not paraphrasing, that's a quote, and I guess I'm kind of nervous about that. I don't know that I believe that.
Well, so actually the caution for using tranexamic acid in intracranial hemorrhage was based on when they use it for aneurysms. Mm-hmm. They would give people that had a ruptured aneurysm tranexamic acid to prevent rebleeding. And actually, when they did the studies, they found no difference in outcomes. And part of that was because the tranexamic acid did prevent rebleeding of aneurysms, but they had an increase in vaso-occlusive events and delayed ischemia and vasospasm. And so the net gain from preventing rebleed was lost with the increase in patients that were harmed by the tranexamic acid. And so to say that it has no side effects, I think is unfair.
And now this is speculation on my part, but I personally believe that there's a difference between arterial bleeding and clotting and venous bleeding and clotting, in that I think I could probably accept an increased risk of DVT in a drug that maybe helped mortality in a patient that otherwise had no chance of living. But an arterial clot is a very different beast. And I think a patient who's maybe at a greater risk of an arterial clot, I would be a lot more cautious about. The problem is I guess it's not straightforward for me to decide, particularly in an acute trauma situation, who's at risk for a venous clot versus who's at risk for an arterial clot.
I mean, I guess I feel confident in treating clots. I'm still not able to raise someone from the dead. So until we get that subset, I think it's a mute consideration.
No, it's maybe more just speculation. If we could, it seems to me if we could identify exactly who would benefit, whether it's arterial or venous or some other thing, at some point out there, everybody will benefit from some intervention. A lot of the question becomes epidemiologically, can I identify the patient who would benefit from my intervention somehow?
And we still don't have the answer if we're giving the right dose, if we're giving the dose too long or too short. And so we don't even know if we're administering it optimally in these patients to help them mortality-wise and safety-wise.
if we were to summarize our analysis of CRASH3, I'd say when I look at how to critically implement the results of this trial into my own practice, I'd say I have come to view TXA after this trial as a bit of a Hail Mary drug for the severe TBI patients. These are the patients who are very likely to die, and I don't really have anything else to offer them. And so I don't know if TXA will benefit them, but it's probably better than nothing if they're going to die anyway. As you said, I personally don't feel like safety's been proven, at least to my satisfaction. So I'm a little nervous about giving this drug to patients who have milder injuries, who are maybe at low risk of death. It seems to me that if you're not destined to die, then giving you a death-preventing drug is probably not going to do you anything positive. It's probably, if anything, going to harm you from the side effect risk. So even though they seem to think that milder injuries benefit from it, I think I would probably reserve this drug for the more severe injuries. Josh, what do you think?
Well, we've kind of had this conversation before. I guess I don't think tranexamic acid is the met form of trauma care. I think the other stuff we do makes more a difference mortality-wise for these patients. I guess I look at it more as the Januvia of trauma care. It's that extra little bit to take that 0.4 or whatever risk of mortality off. And so I think it's a useful armament. And mortality, I think, is a big deal.
Are you going to use it or not?
I'm going to use it. I think by the time I see them in the operating room, it might be a little bit late. I would like to push for earlier use of tranexamic acid.
I think I'm going to use it too, but I'm going to use it skeptically.
I think that's appropriate. And so I guess this concludes our discussion about the CRASH3 study of the value of tranexamic acid in trauma. Dr. Blaine and I will both be available for questions. Please leave them below. We'll try to address them as they come up. Thank you again, Doc Matters, for hosting us. We look forward to your comments in the future.